If I didn't, we do ask that you can go ahead and mute yourself. So good afternoon. Welcome back for our May 2021 Lunch and Learn, Palliative Care. What is it and how can it help? My name is Ellen Dunn. I'm a social worker and program coordinator with Alzheimer Services. And I'm so happy to see so many of y'all here today with us. I just want to go ahead and make a couple of housekeeping announcements just before we get started. So per usual, I'll be able to record this presentation. After the presentation, I'll send a follow-up email just with some notes about the presentation, the link to the recording, and the link to our survey. If all of you could just go in and take that survey for me, we just really appreciate that. It helps us to continuously improve our programs. And then feel free to share the link to the presentation, with anybody that you think could benefit from it. I just want to go ahead too and announce we do have our Walk to Remember coming up in October. It'll be October 9th this year. So keep an eye out for announcements and emails from us on that as well. We are very hopeful we'll be able to have a live and in-person walk this year, which is exciting because things were a bit different last year. So I just want to go ahead and introduce our speaker for today, Ms. Karen Mariano. Karen is a palliative care social worker with Palliative Care of Baton Rouge, associated with the Hospice of Baton Rouge. We are so excited to have her here today to share a little bit about palliative care with us. How does it differ from hospice care? What does it mean and what can it do to help caregivers and your loved ones? So I will go ahead and let Karen take over. We do encourage you, if you have any questions or feedback for Karen throughout the presentation, go ahead and put it into the chat box. All right, Karen, it's all yours.
Thanks, Ellen, and thanks Alzheimer Services for allowing me to come today and speak with you guys. But yeah, I'm Karen, the social worker with Palliative Care of Baton Rouge, associated with the Hospice of Baton Rouge. I started off as a hospice social worker and kind of migrated into palliative care about 3 years ago. And just quick story, I like stories. The way our program really started is that we had a patient who was referred to our hospice program, and she used her right to self-determination and decided, excuse me, that she didn't want hospice. So, excuse me, I'm sorry. So I called her and supported her, and it started with just phone calls, and it went into advanced directives and advanced care planning and things like that. And she became our very first patient, and we started with her in 2017, and we have been going strong, supporting our patients in the community. So hopefully I can shed some light about what I know about palliative care, what I know about hospice, especially with our Alzheimer's and dementia community, and hopefully I can give you some insight. And if you have any questions, please let me know. If y'all can cut y'all cameras on so I can see y'all lovely faces from time to time, that would be great. I would appreciate that. But yeah, let's get started. Hopefully we have some questions or concerns or any feedback. It is greatly appreciated. Just disclosure, I don't say that I'm an expert. I'm just knowledgeable in the field, and I have a lot of experience seeing patients in the community, and hopefully I can help you and your family moving forward. So palliative care, what is it? How can we help? So palliative care basically provides specialized medical care for people with chronic or serious illnesses by focusing on pain, symptom management, and stress relief. Later on in the presentation, I have like a list of symptoms that maybe can relate to your loved one or the person you're caring for. Palliative care initially was technically before hospice, or maybe within like 6 months to a year before hospice. Now palliative care can be introduced to patients once they get their diagnoses, and that's only just because you think about someone's being told that they have a terminal diagnosis. Some of those symptoms may come, like anxiety and stress and pain. So we like to come in as soon as possible to provide that support to your loved one and for your family. The goal is to improve patient quality of life and be an extra layer of support for both the patient and family. And what we mean about extra layer of support is that we're not taking anything away from what your loved one and your family currently has. We want to add to that, and that could be just resources, advanced care planning, collaboration of care. I'll kind of go in details with that on the slides coming up. But just an extra layer of support and just providing either spiritual, social, medical support. And that can be in any setting, and I'll talk about that a little later. Palliative care is appropriate for any age of advanced chronic illness. So we would like to catch it in the beginning or at the diagnoses or at the initial diagnoses, but palliative care is new and very new to the state of Louisiana. The word is not new. A lot of people in hospice use palliative care or use the word palliative, meaning comfort care, but the actual palliative care section of healthcare is very new and very new to Louisiana. So we like to catch it at any stage, or the beginning stage, excuse me, but any stage would most likely be appropriate. Patients can be at any age to receive services. I've had patients as young as 3 months and as old as 102. So it just really depends on the support that family or that patient or that loved one needs, but the age does not matter. Palliative care is provided by a specialty trained team of palliative care doctors, nurses, and social workers, and other specialists such as chaplains, therapists, and things like that, who all work together with your other doctors to provide you with an extra layer of support. So like I was saying earlier, we don't take anything away from what you have going on. We like to add to it. The good thing about palliative care is that we do a lot of advocating and a lot of collaboration with other healthcare professionals just to make sure, I like to say, make sure the right hand knows what the left hand is doing. Because sometimes in the medical field, our loved ones have a lot of doctors and some doctors don't or unable to communicate as much as they can or should. Provides information on advanced directives and planning. This is my favorite part. I love talking about advanced care planning and directives. I love to have my families and my patients or my loved ones prepared for the future, and especially our patients with Alzheimer's and dementia. We want to be able to honor their wishes and hear their wishes and have those plans put in place as soon as possible. And that can go as early as just kind of setting up a living will or healthcare power of attorney, all the way up to assisting families with locating funeral resources and plans and things like that. Also, palliative care helps coordinate care between healthcare professionals. So like I was saying earlier, we don't take away anything from them, we add to it, and we like to collaborate. So depending on the palliative care program you choose or that you're looking for, if that's something that you want, make sure that your nurse or social worker or whatever team you have put in place is making those necessary communication and collaboration with team members. So as I was saying earlier, palliative care does a lot of symptom management, pain control, and stress relief. So I just wrote down or just typed in, a few of symptoms. Now, this is not saying these are all the symptoms that palliative care does, but these are some of the symptoms that I have noticed since I've been with palliative care for the last couple of years. So difficulty sleeping, which is kind of, to me, it's one of the top things, especially with our Alzheimer's and dementia community. It's just difficult sleeping or sleeping more in the daytime and not really at night, which can overwhelm our caregivers. So we definitely want to manage that. The others are constipation, nausea, vomiting, diarrhea, bowel and bladder problems, being incontinent, meaning no longer being able to acknowledge or recognize that you're having a bowel movement. Loss of appetite, weight loss or wasting, and we like to call it like temporal or muscle wasting, where the clothes are fit looser, and you can kind of see the skeletal, I guess you can kind of see the wasting of the skin, so to speak. Shortness of breath or labored breathing, coughing, depression is another big one for all of our diagnoses, and I'll talk about those in a bit. Delirium or mental confusion, weakness, pain, fluid retention, and especially anxiety. And like I said, these are not all of the symptoms. These are just the ones that I've noticed over time. But if there's some family members out there looking for a palliative care program or maybe interested, I would say write down the symptoms that your loved one is having and discuss that with the agency of your choice to see if they can help manage those symptoms. So who's appropriate for palliative care? Now, like I said earlier, these are just some things that I've noticed over time being with the palliative care program that I'm under, but this is not limited to what can be out there. I literally learn about palliative care every day, new symptoms, new onset symptoms, and seeing if we can manage them in the home. So, of course, you have to be diagnosed with a serious or life-limiting illness. I really don't like to use the word terminal because that's more in a hospice realm, even though hospice and palliative care are very close. But we like to, I know for me as a social worker, I like to kind of define those lines so my families can know where they are and kind of where we're going. So I like to use life-limiting illness. 2 or more hospital admissions for the same diagnoses within 3 months, or 3 in the last 12 months. And when we mean same diagnoses, say for instance, your loved one is going to the hospital for shortness of breath or for fluid retention, like the swelling in the lower legs, just going kind of for the same thing. And just to give y'all a little heads up, some hospitals have like a readmission coordinator that kind of watches those things. And usually palliative care is consulted by the hospital based on some of those things. And then, of course, 3 or plus hospital admissions within the last 12 months. That kind of indicates to us that something is going on that we need to watch and maybe need to consult either palliative care or if we are at a later stage hospice, or at least some type of program that can help the family in the home. Persistent or troublesome symptoms despite optimal treatment, and that can be chemo, radiation, dialysis. I know there are some Alzheimer's and dementia patients or loved ones that take certain medications to try to not stop what's going to happen, but kind of prolong it or kind of keep it at bay. And those things are not working. So that's kind of what that means. Artificial nutrition and hydration requested where the patient has a short anticipated survival from underlying conditions such as Alzheimer's. So I don't know what the experience level of our families out there, and I know you guys have tons of resources, especially from Ellen and the staff here at Alzheimer's Services, but some of our Alzheimer's and dementia loved ones pocket food or just don't have the motivation or the lack of knowledge to or the knowledge to eat food. They usually like pocket it in their cheeks or just don't have an appetite at all. And some families elect to do artificial nutrition and hydration or a feeding tube. In those instances, palliative care can definitely be an extra layer of support. Significant weight loss of 5 to 10% over the last 3 to 6 months. That's kind of one of those tell signs that we look for that, an intervention needs to be done. Now, I'm gonna be honest, we don't have anything that's going to just, wave a magic wand and just allow them to eat, but we do have certain medications and certain things that we can do to keep those nutrients in. I know a lot of the social workers that I work with really focus on nutrition, and we talk about Boost and Ensure and Thicket and all of those things, and we encourage our families to, even though the plate that they usually have maybe this this size, to still encourage those nutrients getting in. But yeah, significant weight loss of 5 to 10%. Also, any family or patient is appropriate for palliative care if they have any concerns with the advanced disease progression. And palliative care is a teaching agency, and they talk about disease trajectory, meaning the timeline of the disease or what we expect medically to happen. And that can kind of help family members prepare or be more proactive down the line, whether it's getting home health put in place or hiring sitters, or even ultimately making the difficult decision of placing our loved ones in an assisted facility like an assisted living or even a nursing home. And palliative care can definitely be a support in those places as well. Any major function change. So I know, especially with our Alzheimer's and dementia patients, being able to walk to a couple of weeks later going into a rollator or a walker, or just becoming completely chair and bed bound, meaning that they're only bound to the bed or chair. Palliative care will definitely come in place. And that's not just for Alzheimer's and dementia. When we have our COPD patients that are getting weaker, our cancer patients that are getting weaker from potentially the side effects of chemo or radiation, or just the disease trajectory alone, palliative care would definitely be an added layer of support. Also, any newly diagnosed cancers while currently receiving treatments. I personally don't get this too much, but we do have patients that have a serious diagnosis already, such as liver disease, end-stage renal disease, one type of cancer, dementia, and another new onset cancer comes into play. Palliative care would definitely be a benefit for them. And then also, if a patient is a full code, meaning that they want everything done to sustain their life with an overall poor prognosis. And that's when we need medical staff in and social workers in to talk with our loved ones and be able to help them process and go through those feelings. I did an article, I think about 2 years ago, and just the amount of patients we were getting in were full code. And now, this is no disrespect for any of the medical professionals. I value them, and I think everyone in the field is awesome. However, hospitals and places like that are high paced. So having a palliative care program allows things to like slow down and allow people to vent and talk about their concerns and really talk about the disease trajectory, and be able to have those serious conversations about what do we really want. Do we really want to have CPR, or do we want to allow death to become natural and be a beautiful thing in the transition of processing? I hope that made sense for y'all. Also, patient and families who request a palliative care consultant, most likely they're very appropriate for that program. I've only had a few patients to ask for a palliative care consultation, and decline the services, and that's just because the service didn't fit. However, my agency is not the only agency that has a palliative care program. I would encourage everyone who's on here today, if you're looking for palliative care or looking for a program to help your loved one, or if you're in the medical profession looking for a program to help your patient, please just Google palliative care in this local area and just do your research and see which one would best fit your patient and what they have going on. So I also wanted to just kind of touch on some of the stages of dementia and kind of rationalize things. Now, I know everyone out here and everyone on this Zoom has some sort of knowledge of dementia and Alzheimer's, but I feel like I would be doing you guys a disservice if I don't just touch on it. Now, like I said, this is just things that I've noticed with the dementia patients that I experienced with palliative and hospice over the last few years. So the first stage would be like the beginning stage, which is your loved one having difficulty coming up with the right word or name, just not being able to find that name or find that word, or, I know who you are, but I can't think of your name. Also having difficulty remembering names when being introduced to new people. I kind of have an issue with that too, but who knows? But just having difficulty remembering those new things. They have a hard time trying to kind of put that in their mental Rolodex. It doesn't stick. Having difficulty performing tasks in a social or work setting, not being able to do things that they normally can do in work, not being as social as normal. And it's just because they know something is wrong. They just can't put their finger on it unless they've already been diagnosed. I also find like this stage, most patients are not diagnosed. I listen to families tell their stories, and they were like, well, so-and-so, he just couldn't get my name right, and he forgot the children's name, and he used to be a workaholic and he forgot his work keys, so I knew something was wrong. So kind of like in this stage is where they kind of figure that out and kind of go back and say that this was the beginning stage, and this is how I knew, something was wrong with my loved one, or something was not right. Let me say that. Forgetting material that was just read, also losing or misplacing a valuable object like keys or wallets or a favorite memento or something like that. Experiencing increased trouble with planning or organizing, just not being able to kind of put things in order or be organized. One of my patients is an architect, and he was very organized, and he paid the bills, and he ran the household and took care of his wife and all of his children. And his wife said she knew something was just not right when he allowed her to pay the bills, which he has never done before in the 40-something years that they were married. So they knew it was time to go speak with someone, and for sure he was diagnosed with dementia at that time. So moderate stage, as you can see, the symptoms start to go up a little bit. So being forgetful of events or personal history. I learned in grad school, one of my professors, Dr. Wilkes, if some of y'all went to LSU, I remember him telling me that dementia or Alzheimer's is like an onion peel, and those layers that fall off is their memory. So just being forgetful of some of those things or events that may have happened in their lives. Feeling moody or withdrawn, especially in social or mental challenging situations. And I feel like that's just because they're trying to be who they normally are, and they know that something is wrong or something is not right, and it causes them to get frustrated or angry or upset, which those feelings and emotions go to the family and the loved ones as well, because we want them to be happy, but they know that something is not right. Being unable to recall information about themselves, like their address or phone number, or even the high school or college they attended. Experiencing more confusion about where they are or what day it is. I noticed a lot of Alzheimer's and dementia patients, their families kind of put signs everywhere in the house to kind of remind them, today is, Lord, look at me, what today is. Today is May 12th, and it's 12:24, and it's gloomy outside, things like that, because they have issues with confusion about where they are or what day it is. Requiring help choosing proper clothing for the season or occasion. I definitely see that a lot. We have, especially our ladies, they have difficulty wanting to put on undergarments. I hope I'm not appropriate with that. Or they may put on their clothes the opposite direction, or clothes that may be too big or too tight, but they definitely have issues with getting the proper clothing on. Having trouble controlling their bladder and bowel, experiencing changes in sleep patterns, such as sleeping during the day and becoming restless at night, showing an increased tendency to wander or become lost. And this is honestly the perfect stage for palliative care, because we can have those conversations, reach out to Alzheimer's services or any other services that are in the community that can help make sure the house is tailored to the patient, make sure there are things put in place so they don't wander out or become lost, because we would hate for that to happen. Also demonstrating personality and behavior changes, including being suspicious, having some delusions, become combative, and then repetitive behavior like hand wringing or like tissue shredding. I have a patient that's in the moderate to late stages, and she likes to flip through mail. So her daughter just gives her all kind of envelopes just with stuff in it, and she likes to just open them, look at them, close them, but it keeps her from wandering out of the house. Another suggestion, that I've seen is, I don't know what it's called, but it's like a little fidget item, and it has like buttons and a knob and a switch, and they can kind of fiddle with it, and it kind of keeps them, at bay for a good while. Now, the late stages, this is when either palliative or hospice would be consulted. And I say that because depending on how late it is, palliative care may not be a fit for the patient's needs, and they may require the extra layer of support that hospice can provide. And I'll talk about the difference in the level of cares in just a minute. But with the late stages, they require around the clock assistance with daily care. So that can either be with the family or sitters or caregivers or family around the clock. They lose awareness of recent experiences as well as their surrounding. They have sometimes no clue where they are, or they think that they're in like their mother's home, but their mother has passed away long ago, or in a home that they grew up when they were smaller. They also experience changes with physical abilities, including walking, sitting, or eventually swallowing. So this is when they become more chair and bed bound, have difficulty walking, difficulty talking and doing ADLs or activities of daily living, which is like dressing, bathing, transferring, which is going from like bed to chair or chair to bed or from one place to another. Sitting down may be an issue for them, and then also swallowing may become an issue as well. Not being able to take their medications or hold down food or be able to swallow food or even water. In this stage, they become more vulnerable of infections, especially pneumonia, also a lot of urinary tract infections, possibly bed sores because the skin gets very, very thin and weak. So at this stage, we would definitely have to sit down. If no program is involved first, we would have to sit down and discuss palliative versus hospice. So I actually found this checklist last night as I was kind of going over this PowerPoint, and it's just kind of asking, does my loved one qualify for palliative care? And this is just a simple, these questions here that'll kind of determine, should you pursue palliative care, or should you pursue something either before palliative care or something higher than palliative care, such as hospice. So the questions are: has your loved one been diagnosed with a serious or chronic illness? Does this illness require pain management or ongoing care, which would be chemo, radiation, physical therapy, occupational therapy, speech therapy, dialysis, lab work, all of those things, ongoing care? Does your loved one have a physical pain that is not under control? Is your loved one having difficulty or a difficult time coping with their illness? Their illness is bringing on a lot of anxiety or depression or just sad feelings. Does your loved one find it hard to understand their illness? Just not understanding what's going to happen or what's this going to look like. I know a lot of my cancer patients struggle with the effects of chemo. They assume that chemo is just going to quickly cure them or get rid of the cancer, when all actuality, chemo may or may not do that, but chemo also has side effects as well as the cancer. So just helping them understand that they may have difficulty doing that. Does your loved one have an advanced care planning in place so someone will know their wishes? And honestly, if you answer yes to any one of these questions, your loved one may qualify for palliative care. I'm always going to say, when in doubt, call it out. Just if you're in doubt or if you're on the fence, just call a local palliative care agency in your area. Speak with your doctor, speak with your home health agency, and just see if this extra layer of support will definitely help. So hopefully y'all can take a little screenshot of this. If not, I think Ellen is going to provide this handout, or it should be on the recording. I believe so. But yeah, if you answer yes to any one of these questions, then 9 times out of 10, your loved one qualifies for palliative care. So now I want to talk about palliative care versus hospice. I'm going to talk about the difference between the two, and then I was able to locate a chart that kind of separates them, but also shows that palliative care and hospice kind of does the same thing too. It's just aligning or having a program that align with your goals. So palliative care is for people with serious illnesses. Their life expectancy is less than 3 years, and that's just an estimate. We have had patients on our program for for 3 years or since we started, and their symptoms are being managed, and the support that we provide is all they need. But we like to look at people with a life expectancy of about 3 years. I was doing some research with another hospice and palliative care program in Lafayette, and we were looking at the timeline of things, and the timeline for someone to effectively benefit from all of the services that palliative care can provide is usually 2 to 3 years. And I know that sounds like, oh, my husband or my wife is going to be on a program for 3 years. Well, palliative care has some flexibility in that. And if you guys have some detailed questions on that, I can talk about that too. So yeah, serious illness, life expectancy of at least or less than 3 years or 3 years or less. Palliative care allows you to seek aggressive and curative treatment. So like I said earlier, you can have chemo, radiation, dialysis, lab work, physical therapy. All of those services can be in line or be in place while your loved one is receiving palliative care. Palliative care offers a broader eligibility criteria. As of right now, we don't have any mandates or any criteria that we need to go by to say this person is palliative care eligible. You just have to at least meet one of those questions or have something going on with your loved one. We've even had patients who have had major surgery. I have a patient who had like a jaw transplant or a jaw surgery. I think she had like some degeneration in her gums, and her jaw and mouth had to be reconstructed. And we're supporting her with palliative care right now, going out and giving her the support that her and her family needs. May or may not provide DME, transportation, CNAs, or supplies. And I said may or may not because that really depends on the palliative care agency that you are choosing. So I would definitely, that would be one of my top questions if that's what you're looking for. Some palliative care programs do not provide it at all, DME or durable medical equipment, where other programs don't offer it, but they can get you in line to get the necessary orders to have the equipment delivered to you. Unlike hospice provides that. Palliative care, we have to go through your insurance to get those items. Maybe by appointment only or as needed. Some palliative care programs are only available Monday through Friday and work on an appointment base or as needed visits. So that's what I was talking about, the flexibility. So some patients in my program, I have not seen in months. And that's because my goals and their goals for me and my goals for them are met. So I'll call them and check on them and see if they need anything. And if they don't want me to visit, I don't have to visit. So it's really tailored upon the patient. So that's why I'm trying to give the just general of it, because each different person may have a different need. It may be more medical, it may be more social, it may be more spiritual. So we offer all the three. Palliative care is accepted by Medicare Part B, and you may or may not have a copay, but it's usually the copay that you get when you go to your doctor. I like to tell people palliative care is like an in-home doctor's appointment with a social worker aspect, because there is a nurse or nurse practitioner that does the same or somewhat the same that they would do in a doctor's office. So depending on your insurance, I have learned or still am learning that some insurance agencies or insurance companies have their own palliative care program, or they are open to you finding your program. So another way to look for a program is speak with your insurance provider. They may or may not have a palliative care program, or you may have one in mind and you want to see what your co-payment may be with them. Some palliative care programs are nonprofit, some are for-profit. Some non-for-profit agencies may not even require a co-payment just because they work strictly on donations and they don't reach to gain any financial support from the patient or family. Palliative care services and goals can be performed along with the care of a primary care physician. So most programs or most palliative care programs that I have researched would prefer that a primary care physician is involved. That way, any changes or things that the palliative care program will make, that particular primary care physician will know about as well. Hospice services and goals, you have to have a terminal illness, prognosis of 6 months or less based on Medicare guidelines. And I say that because the hospice agency that I work for, we have patients that will exceed that 6 months, but they still meet criteria. Can't pursue any curative treatment. So the focus of hospice at that time is strictly comfort focused. I know for some of our dementia and Alzheimer's families that you guys take medications for that, and that may be discontinued, especially if it's not preventing or doing any benefit for your loved one. Must meet end of stage disease criteria, and that's based on the Medicare guidelines. Even if you have private insurance, most hospice agencies go by the Medicare end of life disease criteria. Of course, with hospice, all of your medical equipment, medications for comfort, supplies are covered at 100%. Hospice is available 24/7. And what I mean by that, we don't stay with you 24/7, but we are available. Most hospice agencies are visiting services, and they do visit with a nurse, CNA, which is a certified nursing assistant, social worker, chaplain, and a volunteer if expected. Some hospice agencies provide an inpatient unit, and that inpatient unit will be either for respite, for caregiver relief, or what we like to call general inpatient, meaning that there is a symptom that needs to be managed with 24-hour hospice care. So I hope I explained that so y'all can understand. If not, you can ask away after. And then, of course, hospice is covered by Medicare Part A at 100%. Some private insurances may have a different deductible, but if you have Medicare, Humana, People's, that turns into a traditional Medicare, and it's usually covered at 100%. So this is the chart I was telling you guys about earlier, just talking about palliative care and hospice. And then also in the middle, you can see where they both do the same thing. So both palliative care and hospice improve the quality of life for patients with serious illnesses. And that could be medically improvement, social improvement, spiritual improvement. But the goal is to improve the quality of life for the patient and their family with a serious illness. Both palliative and hospice provides emotional, spiritual, physical, and social support to effectively manage any symptoms. And then, of course, you can see on either side what palliative and hospice does. I kind of said that earlier, but I thought the chart would kind of, for me, I'm visual, so the chart kind of helps me out too. So delivering palliative care for dementia, Alzheimer's patients. These are just general guys and well, ladies and gentlemen, but it's definitely catered to what you have going on and what you need. So like I said, you know, get those questions down, get your needs down, and look for that program that will best suit you. So when delivering palliative care to dementia and Alzheimer's patients, the ultimate goal is to improve quality of life and ease the stress from the family. Palliative care helps treat some of the symptoms of Alzheimer's, such as depression, anxiety, and difficulty sleeping. That's not as exclusive to the only symptoms, but those are the most common. Palliative care involvement results in a shorter hospital stay if the individual is hospitalized. And usually that's because we ask the family to, hey, let us know if you have to go to the hospital, or if we have to send you to the hospital, we can call the directors and, well, not directors, the nurses and doctors there and say, hey, Mrs. So-and-so is my patient with palliative care. We're providing in-home palliative care for them. Can you please keep us updated with her plan of care, or you know, what the doctor or hospitalist advises on her program, and we'll be more than happy to accept her back in our program once she returns home. So that helps our social workers and doctors and nurses who are in the hospital with their exit strategy. They know that they have a support system in place, and sometimes they let our patients come home quickly or quicker. We help coordinate care between healthcare professionals. I know my nurse practitioner and I are constantly talking with other social workers from other offices, doctors, neurologists, normal PCPs, other specialists, to kind of let them know what we see and what we're doing. We like to help paint a picture of what we see in the home or in the facility or wherever our patient is. We help you discuss what's important to you, how and where you want to be cared for, and what level of care you want in the future. Most palliative care programs are very goal-oriented, and we work off of that. So based on the goals that you give us, because we don't come in and say, hey, we're going to do A, B, C, D, E, F, G. It's what are your goals? What would you like to see happen? If you can look down the line of a year, what would you like checked off as far as the care of plan or the plan of care, excuse me, or the goals or objectives for your loved one? And we try to check those off and help support families through that. And it could be other things. This is just kind of what I put together. I honestly put this together on my last dementia patient that I got a couple of weeks ago, but it's very goal oriented and is based on the patient or loved one. So I wanted to do a case study. So if Miss Ellen can help me, I just wanted to see if what I'm relaying to you guys understand. So this is a case study. Mr. C is a 70-year-old male who lives with his wife, Miss Ann. He was diagnosed with dementia about 5 years ago. He can still walk around the home, but he can no longer drive. He's receiving physical therapy at home due to a fall he had this month. He has difficulty remembering names of his family members, but he is definitely comfortable with Miss Ann. He was hospitalized twice this year for shortness of breath and sent home with home oxygen. However, his wife, Miss Ann, is becoming overwhelmed with the care and could use some help. Do you guys think that this is a palliative care appropriate patient or a hospice appropriate patient?
If you guys would like to go ahead and put your response, whether you think it's palliative or hospice, in the chat, that way myself and Karen will be able to see them.
How can I see it, Ellen?
If you look at the bottom, Karen, you might see a button that says chat.
I think it's
for yours, it might even be at the top too.
It might be at the top. Let me see. More. Okay, yeah, chat. Okay.
Looks like almost everybody so far has said palliative.
Hey, Saida. Hey, Ashley. Hey, Miss Carol. Hey, y'all. Y'all, I'm so excited. I'm literally a visual person, so to see y'all names, it's like I'm excited. Palliative. Yep, this would be a palliative care appropriate patient. So one more case study. Mrs. K. Evans is an 80-year-old female with a diagnosis of dementia. She is wheelchair and bedbound. Her family now have sitters in place. Hold on, I can't see that. Oh, oops, how do I go back? There we go. Mrs. Evans now has sitters in place as she needs help with her activities for daily living. Years ago, Mrs. Evans decided to document her wishes and elected DNR, do not resuscitate, as her end-of-life goals. She's now sleeping between 12 to 14 hours daily, and she also has difficulty swallowing and communicating. Palliative care or hospice? Hospice. Y'all make me feel like I know something. Okay, hospice. Yep, she would definitely be more appropriate for hospice. Now, with both of these case studies, y'all, it is totally up to the family to decide what they want to do. We definitely, in palliative care, we talk about both and what both of them mean, but it's ultimately up to the family. We like to support them in whatever their decisions are. Hospice. Okay. Thank y'all for participating in my case study. So the next thing I want to talk about real quickly is advanced directives, preparing for the future. Now, as social workers and care managers and nurses, we probably have seen all sorts of advanced directives, living wills. They can be written by lawyers, they can be done by doctors, they can be done by witnesses. So I just wanted to touch on the main two that we see quite often and that our loved ones or that our families taking care of our loved ones may see on a typical basis. So 5 wishes. 5 wishes is a packet that talks about number 1, the person they want to make decisions for that person when they can't, what kind of medical treatment, how comfortable they want to be, how they want people to treat them, and what they want their loved one to know. I think this is the greatest document for people who are in the in-between because it's scenario based. If y'all ever looked at one, or like if there's some families out here, if you never seen this before, Ellen, do you guys have copies available here?
We do have some copies here.
Okay, so Ellen does have copies. If you guys are in the area, you can stop by. It is online. I apologize that my picture is a little fuzzy. That was the best picture I could find, but it's very scenario based. In the state of Louisiana, this document does not have to be notarized or signed by a lawyer or a doctor. You just need 2 witnesses and it makes it valid. For those family members out there, just speaking for us social workers and medical professionals, we prefer not to be a witness just because it's a conflict for us. So if you're ever working with a social worker or someone in the medical field and they choose not to, that's just kind of why. But it can be 2 neighbors, 2 friends, 2 family members, and that makes it valid. If we have any other families that are out of state, which I doubt, on the back of the packet, it shows what you need to do for your state. But I think this is an awesome document, and it helps the family kind of ask those questions. And even if you have trouble asking these questions, our families out there, I usually say one thing. If you're watching TV and you see like Grey's Anatomy or ER or one of those shows, have you ever seen something happen on TV on one of those shows that you do not like or that you do not want? And either it starts a conversation or it gets them to thinking. I'm always a plant a seed person. I can plant a seed and come back. That's what I enjoy most about being a social worker, and also enjoy about being a social worker in palliative care. The next document is the LaPoste document. It's a Louisiana physician's order for scope of treatment. I'm starting to see this a lot out there, especially in our hospitals. My godmother, not to be too much of stories, but I love stories. My godmother, her medical team is at a local hospital, and they actually sent her home with a packet that had this document, 5 wishes, a living will, which talks about this differently, and a healthcare power of attorney. So I thought that was awesome. But this is a Louisiana physician's order for scope of treatment. It mainly talks about resuscitation and the medical interventions. So if you ever see this form, it mainly talks about basically, and not to be just blunt, but it talks about what you will want done or what your loved one will want done if their heart stops. This doesn't negate any treatment. This doesn't negate any surgeries. Basically saying if your loved one would stop breathing, what would you want done? Now, this document must be signed by a doctor. Most palliative care programs offer this document. Most doctors' offices offer this document. It can be signed by a doctor, and once signed, it's valid. Copies of this document also is valid as well. I usually tell my patients to leave, and it doesn't show like this, guys. It's a gold form. With Black handwriting, but I usually tell my patients don't file it. Like most of the times we have our like our file cabinet with all of our documents and stuff. This form can actually be placed on your refrigerator, somewhere close, somewhere where everyone can see it, because if the ambulance is called, 9 times out of 10, they're going to ask, hey, does your dad have a LaPoste? Does your wife have a LaPoste? And you can just go to it and it's right there. And it's really beneficial, you guys and ladies, because when something happens or something traumatic or a serious event happens, our minds are flustered and we just can't process that. And this paper, I don't have to say anything. Here, my dad had this LaPoste, and they can go and follow the wishes on that. But it talks about resuscitation, medical interventions, if the family wants artificial nutrition and hydration, and who it was discussed with. And I love talking about this form, y'all. I don't know if y'all can see or feel my excitement, but I love talking about this form, and I think it is so necessary for all of our patients that are at least 50 and older. And even for, unfortunately, our patients that are younger than that, and for our babies that we have in the community that are medically ill. So yeah, those are the two documents that I wanted to discuss, but there are other documents out in the area. You can Google documents, you can Google templates. If you plan on going to a palliative care agency or a hospice agency, they have tons of material to share for you. But if you're choosing not to do either at this time, please go to your primary care physician and seek it. So basically this talks about when can I start palliative care, or how to get palliative care. Like I said earlier, if you feel that your family member needs palliative care, talk with your doctor or your healthcare team. A recommendation or a referral, that's what we call it, for palliative care can come from your primary care physician, a specialty physician such as a urologist, neurologist, oncologist, or any home health services. So if you have a home health agency and they feel you would benefit from palliative care, they can make a referral. And the family members, if you feel that you, your loved one could benefit from our program or any palliative care program, reach out to us and we can make the necessary calls and collaboration to get what we need to start servicing you and your loved one. It's good if you start with the physician that is most involved in your care. This could be multiple doctors, so you may have to have multiple conversations. Some doctors may feel that you're not ready yet, or that your loved one is not prepared yet, but put your foot down. Let them know what you need. Let them know what type of support you need, because there are people and social workers and nurses and therapists and tons of healthcare professionals that are waiting and willing to help you guys. If your loved one does not have a physician, just Google palliative care in your area and reach out to those people. Most palliative care programs have a medical director that can review some records from either the hospital or wherever you've been before and make a recommendation to palliative care. These are some resources that I got or that I used to get some information. Most of the information was really just based on what I've learned in the last 3 to 4 years. And that's it, y'all. Do y'all have any questions?
Erin, thank you so much. That was a wonderful presentation. We actually do have a question in the chat.
Okay.
Someone asks, does the LaPoste replace a medical living will?
No, it depends on what that will is. So when you say living will, there's like a living will declaration where it says like, I wish to withhold all treatment except nutrition and hydration. They kind of go hand in hand because the LaPoste document talks about that too. So the LaPoste document may say, I want to be a DNR, but I want artificial nutrition and hydration. That living will indicate the same thing. It's just the LaPoste have it in 2 sections and the living will has it all together. I hope that answered your question.
Thank you so much. And if anybody else has any questions for Karen, go ahead and put them in the chat now. We have another question that came in, Karen. Can palliative care be provided in nursing homes?
I'm gonna be honest, it is very difficult in nursing homes, and difficult because nursing homes have a doctor and a nurse practitioner and a social worker, and nursing homes are a level of palliative care. Now, if your loved one is in like an assisted living facility or I hate to say like a group home setting, but we do have, or palliative care has been served in a lot of assisted living facilities, but nursing homes already provide a level of palliative care. So it's kind of difficult to be in, but I would say if you're looking for a palliative care program, that facility may already have something put in place, or they may have a contract with a palliative care program that may be able to go in. My agency is contracted with a few nursing facilities, but that's based on the great reputation that we have with our hospice agency. So I hope that answered your question.
Yeah, that was helpful. Thank you. I have another question, Karen, for you. I know you mentioned earlier that palliative care is often goal-driven. Can you give some examples of common goals that families may come up with that they would like palliative care to assist them with?
Sure, absolutely. The main one that I get as a social worker is resources, and that could be Meals on Wheels, that could be providing sitters, that could be completing a Medicaid application. A lot of families also talk about being comfortable and what that looks like. I mean, you can tell me you want to be comfortable, but what does that mean to you? Some people just want some support in place until their loved one is ready or appropriate for hospice. And then so we do a lot of preparation, just kind of checking vitals, making sure that they have a post or some type of living directive or living will in place. So we do a lot of that. So comfort focused is a goal. Some people want to gain strength and they don't want hospice. They want to get back to their baseline as much as they can. So that's consulting physical therapy, locating a home health agency. I have a sweet man right now. He wants to gain his strength because he wants to dance with his wife for his anniversary in 2 months. So that's his goal, and we're going to do what we can to make that happen. So those are some of the goals that we get.
Thank you. We had another question come into the chat. Can a feeding tube be handled outside of a facility, like by the family at home?
Yes, ma'am, it can. So most patients who get a feeding tube, it's in a hospital, it is a surgery, and the hospital has to train family members on how to use it before that person can be discharged. So definitely a feeding tube can be something that's done in the home. Now, I'll be honest, the supplies and things for the feeding tube can be very overwhelming because all of those supplies are constantly sent to the home, but it's definitely something that can be done either bolus, meaning you're doing it yourself, or to a pump that will do it for you. But it can definitely be done in the home. Yes, ma'am.
Okay. Thank you, Karen. That's all the questions we have for now. I just want to thank you so much. This has been a spectacular presentation. I've learned so much myself, and so I'm hoping everybody else has as well. But thank you for, sharing this information with us and giving us all these wonderful examples as well. And thanks to everybody who participated in Karen's great case studies. It's always nice to have some participation in this Zoom world that we're in. So
yes.
Thank you, Karen. Thank you to everyone who joined us. We look forward to seeing y'all next month. And Karen, I'm going to save this chat too. There's a lot of nice comments in it, so you can see these. So, well, thank y'all so much. We will see you guys in June. Hopefully, we'll have a presentation on medications for your memory. So we look forward to seeing everybody then. Thanks again, Karen.
Thank y'all.